Greetings to the audience. Today, we are analyzing a viral video that represents a one-way ticket to the ER, the forbidden snow cone. In this footage, we see multiple red flags: eyes sitting directly on the ground, rusty tools, and no gloves. This isn't just an unhygienic snack, it's a biological hazard waiting to happen. Frozen street foods are breeding grounds for dangerous pathogens like Escherichia coli, Staphylococcus aureus, Salmonella, Listeria monocytogenes, Shigella, Vibrio parahemolyticus, and Vibrio cholera. To understand the real-life consequences, we will present our first clinical case. Imagine this. A healthy person buys one of these snow cones. They enjoy the bright colors and the cold ice, but the clock is already ticking. 3 to 5 hours later, the nightmare begins. Suddenly, they experience hypersalivation, intense nausea, and violent projectile vomiting, followed by a severe abdominal cramps. This rapid onset is the classic calling card of our first culprit, Staphylococcus aureus. What's happening inside? The real villain isn't just the bacteria, but its secret weapon, staphylococcal enterotoxins. Think of these as a microscopic landmines that were already in the ice. They are incredibly resilient. Freezing doesn't stop them and heat doesn't destroy them. Once ingested, these toxins act as super antigens. Look at the mechanism. Instead of a normal immune response, the toxin hacks the system. It binds massively to MHC class II molecules, forcing the body's defense cells, the T cells, to overreact. This creates a cytokine storm, a massive release of IL-6, IL-8, and TNF. This isn't just a stomachache, it's an uncontrolled inflammatory explosion. In vulnerable patients like children, this can escalate into systemic shock and multi-organ failure. It's important to say that the severity of the symptoms depends on the amount of the toxin ingested. To confirm our diagnosis, we use PCR and bacterial cultures to identify the specific genetic type of the toxin. Antibiotics are ineffective here because the toxin is already in the system. The bacteria might be gone, but the poison remains. The priority is aggressive rehydration with electrolytes while the body naturally clears the toxin. While we wait for recovery, science is looking at new frontiers, like bacteriophage therapy, to fight these resistant strains. But for now, let's look at our next case involving a different pathogen.
Let's rewind and play a different scenario. This time, our patient doesn't get sick immediately. They leave thinking everything is fine, but the clock is still thinking. At first, the patient develops persistent diarrhea, severe abdominal pain, and in some cases bloody stools and fever. This is the clinical signature of Escherichia coli infection. E. coli is normally part of our intestinal microbiota, but when it contaminates food or water, it becomes a pathogen. As we mentioned at the beginning, pollution conditions are observed in the video. These factors allow transmission through the fecal-oral route, especially in a nutrient-rich production like ice cream. Once ingest pathogenic E. coli driven by adhesion to intestinal cells toxin production and thus tissue damage. This leads to a key clinical clue: bloody diarrhea. And what we observe: intestinal inflammation, dehydration, leukocytosis, and inflammatory response. Diagnosis is confirmed through stool culture using selective material like McConkey or EMB-agar, followed by biochemical identification. Molecular methods such as PCR help detect virulence genes, especially in high-risk strains. If untreated, diarrhea persists, dehydration worsens, and several complications can develop, such as hemolytic uremic syndrome, which may lead to kidney damage. Treatment depends entirely on the patient's condition. The patient starts with oral hydration and that's sufficient. Then in other cases, intravenous fluids are required. Finally, in several cases, antibiotics may be avoided because in toxin-producing strains, antibiotics can increase toxin release and worsen the disease. New therapies such as bacteriophage treatments are being explored, targeting E. coli especially without affecting beneficial bacteria. With proper management, most patients recover completely. However, severe cases may lead to complications such as intestinal or kidney damage. So while Staphylococcus aureus acts rapidly through toxins, E. coli follows a slower, more invasive path.
But wait, we can turn around the tables to yet another scenario, another microorganism that cannot wait to meet its new target. Lurking behind the nuclear winter palette in which the IT is used is the VIP pest for Vibrio cholera. It has an incubation period in which 5% of cholera cases will develop symptoms by 0.5 days and 85% by 4.4 days after infection. The transmission occurs via the fecal-oral route through contaminated water, and worse yet, the symptoms begin suddenly without some indication. Curious, isn't it? Going from I'm fine to I need a hospital in a matter of hours. But before that, let's go through what B. cholera experiences. First, it has to face its first major barrier, your own stomach. To reach the small intestine, the microorganism has to pass through the stomach and survive the low gastric pH. The problem is that B. cholera isn't resistant to acid, therefore it requires a large inoculum to survive the gastric acid in the stomach. Once it's managed to pass, it enters the colonization phase of the small intestine, moves towards the epithelial cells, where it adheres, multiplies, and begins to produce its secret weapon, the cholera toxin, that eventually endocytosed by the intestinal epithelial cells, unleashing the chaos we mentioned earlier. B. cholera is the cause of profuse painless diarrhea and vomiting without fever, although the diarrhea can vary in severity, in which severe cases may present with hypovolemic shock due to significant fluid and electrolyte loss. While the initial diarrhea may include fecal matter, the classic presentation consists of watery, foul-smelling mucus described as rice water stools. The doctor will notice without difficulty in anatomical changes such as sunken eyes and the skin that loses its elasticity due to extreme dehydration, this being a crucial factor to identify the disease because the rate of fluid loss and the high concentration of sodium in the stool distinguish cholera from other diarrheal diseases. But let's go into the laboratory because what B. cholera does to the body is not just discomfort. So to confirm the culprit, bacteriological or molecular tests are used to detect the presence of the bacteria or its toxins. But before giving up all hopes, once the disease has been identified, in this case it is of utmost importance to act immediately, providing radiation treatment as this poses the greatest dangers to our body. Although this saves lives, antibiotics can reduce the duration of diarrhea and the shedding of bacteria, helping to break the chain of transmission in the community. After everything that happened, you will have survived quite an odyssey.
Imagine buying an ice cream cone to cool off, and instead of being a Harlem Street, it becomes the gateway for Salmonella. This bacterium is transmitted through the fecal-oral route, mainly through contaminated water, dirty surfaces, and poor food handling practices. In this case, the ice cream cone is the vehicle of transmission. Once inside the body, Salmonella must first survive the acidic environment of the stomach. If it succeeds, it reaches the intestine and begins the infection. There, it uses its fimbria, small structures that act like hooks and allow it to adhere to intestinal epithelium. Then it activates its type 3 secretion system, a kind of molecular syringe that injects proteins into host cells to invade them and promote colonization. This triggers intestinal inflammation and disrupts water and electrolyte absorption, causing the typical symptoms of non-typhoidal salmonellosis: diarrhea, nausea, vomiting, abdominal pain, fever, and chills. These symptoms usually appear between 6 hours and 6 days after consumption and typically last 4 to 7 days. In most cases, this form present is a self-limiting acute gastroenteritis. As for treatment, most cases of non-typhoidal salmonellosis are self-limiting and require only supportive care, mainly rehydration and electrolyte replacement. However, in severe or systemic cases or in vulnerable patients such as children, older adults, and immunocompromised individuals, antimicrobial therapy is required. The most commonly used antibiotics include azithromycin, ceftriaxone, and ciprofloxacin, select according to the patient's clinical condition and the bacterial resistance profile.